The treatment of AVMs today is quite a challenging decision, perhaps one of the most challenging decisions we have to make in cerebral vascular surgery. So taking consideration the CAT scan, MRI, cerebral angiography, with 6 vessels, cerebral angiography is extremely important so that one can evaluate the size of the arteriovenous malformation, the shape, if it's compact, diffuse, location is extremely important, the type of flow into this lesion, and certainly clinical information such as patient condition, and that allows us then to look into all the possibilities: endovascular embolization, surgical resection, stereotactic radiosurgery, or a combination of these therapies, or sometimes no treatment at all. In this case, we decided to start with embolization, and we always have the goal to have a occlusion of the malformation, and this is certainly in this case, as the first step would be to obtain the cerebral angiography to confirm the findings from the diagnostic angiography. We use in this case a select system and a neuron, 6 French axis, and once we got into the right internal carotid artery, we reconfirmed the diagnostic pictures. We then decided to establish a pathway to the AVM, and this is something that I think that is very important because the morbidity of embolization a lot of times comes from access. So having mapping of your trajectory so that you avoid having too many catheterizations of vessels in passage is quite helpful. You do a 3D spin, and then you can use your toolbox to select a pathway to where your vessel of interest is, and this will then superimpose on your roadmap, and that will allow you to have a basically a highlighted path for your microcatheter. In this case, we chose to use a Marathon and a Mirage microwire. Not infrequently, if we have a challenge, and as you see, you're coming around the band on this vessel, and right at this point, we have a little bit of difficulty getting to our plane. We catheterize actually a vessel in passage there, but you can clearly identify that and reroute because of the presence of having this pre-planned trajectory. Sometimes if this is not easy to do, like in this case, you see the microcatheter went into the wrong path, so now you redirect, and sometimes in these cases we may have to change and use a Synchro 10 microwire to add a little bit more ability to redirect your catheter and find your path. So a combination of using flow guidance, by you see now we pull the microwire back and allow the microcatheter go forward using just flow, and then at times you may need to use the wire to access your target, but that can be done with a combination usually today or in the United States of Mirage and the Synchro 10. I try to get as deep a position as I can into the nidus, and here you see also a view of the position of the microcatheter in relation to the AVM nidus, but also microcatheter injection is quite important. And the setup here, as you can see in the lower left corner, is quite simple. At this point, we have only a 6 French guide with a microcatheter, Marathon microcatheter into the AVM, so I don't use any heparinization during these cases, mainly to avoid the potential subarachnoid hemorrhage when you push, you remove the microcatheter at the end of the procedure with a cast. So that traction is something that I avoid, at least until we have available our detachable catheters. I do like the navigation of this microcatheter, the Marathon, and it got us in a very good position. I have started using here Onyx 18 in this AVM, and the preference here is because of it's a relatively, the flow of this AVM is not, in my view, a high flow AVM, and this is also allowed me to build, as you can see here, a very careful initial plug into the proximity of the microcatheter without having much of a reflux at this point. The ideal pedicle that we picked as an important aspect of this decision making is to a pedicle that is as straight as possible, as well as with the least amount of branching vessels, so that you can allow yourself to have reflux. And the other important aspect is that you're able to, the larger pedicles will in general allow you to have a safer catheterization. So those are very important easy initial thoughts you have to have when you choose the area that you're going to be catheterizing or approaching the AVM. The patience is a key, and the use of blank roadmaps is very important as we gradually build. It's almost like you have on the middle of the screen the appearance of the nidus. So what we're doing with the cast with Onyx at this point is just to reproduce the image you see on the middle of the screen by gently tailoring your embolization so that it will fill that shape of the initial nidus of the AVM. And the key aspect of that is to know when to stop, so the continuous observation of the AP and lateral planes, and know that you are, I do choose, as you can see on the right side as the model, the kind of mid-nidus view, and so that you don't get too much of artery or too much of vein. You're basically looking to the size of the nidus as much as possible as a model, so then you can gradually start to sculpture this nidus using the Onyx then. And the key part of this is certainly avoid to have too much reflux. Also is very important to not get too much in the venous side, so that you can lose a lot of Onyx or embolic material on the venous side. I think that the key part is recognize that you have achieved the venous side, and then interrupt your embolization and try to reroute into a different portion of the AVM. I try to wait between the embolizations. If the liquid embolic is going to the wrong direction, I tend to wait between 30 seconds to 2 minutes prior to then start a new injection. The very important aspect of this is that you have to continue your microcatheter inside of the cast. If you remove the microcatheter from the cast of Onyx, there's a good chance that this material will then polymerize inside of your microcatheter. So keeping the microcatheter within the cast without pulling back during the embolization is very important. It's also very important to not wait too much more than 2 minutes, because there is a chance that the material could solidify inside of the microcatheter. And gradually, one of the advantages of this material is that you can do angiograms, as you can see now, during your embolization, and assess the degree of occlusion of this malformation. At this point, I feel that we have to continue the embolization until you completely occlude this AVM, since you have a significant slowdown on the venous side, and it's very hard for me to stop the embolization and stage this at this point, because I would be concerned that we have compromised the venous drainage of this malformation. So part of the concept of embo cure is to really have certainly a lot of patience, but be very conscientious that once you start in this process, you may not be able to stop this now without having a complete occlusion, angiographic occlusion of the AVM, like we see on this final views now. And it's if this was not the case, and I felt that I could not embolize anymore, this patient likely would have to go to open surgery to remove the AVM just after the intervention, to avoid the risk of a hemorrhagic complication. We also like to say that these AVMs are only considered cured in our place if they have a complete angiographic occlusion, and as well as an MRI evidence of no contrast inside of the onyx cast, or where the used to be the nidus. So it's extremely important to, before you consider this AVM to be successfully treated, to have a confirmation with an MRI. This patient did very well, was discharged home within 3 days. This is the MRI confirming the occlusion of the malformation, and the follow-up angiogram at 18 months. And we don't necessarily advocate removal of these AVMs if they remain occluded, so we'll keep a follow-up with the MRIs on a yearly basis. Thank you for your attention.